detail of our chairman. Pablo me dice que no puede entrar al...
Sí, ya me está escribiendo el WhatsApp.
Impecable. Listo, decime
si...
vos, así yo doy la bienvenida, hago la apertura y lo presento con el CV.
Ya estamos.
Bueno, buenos días a todos. Para la Cátedra de Oftalmología del Hospital de Clínicas es un verdadero honor tener la presencia de un experto como el profesor Marc de Smet. Y un poco para los que no los conocen, les cuento que el doctor Marc Smet es un médico nacido en Canadá, en la cual estudió. Luego estudió en la Universidad de estudió en Ottawa la licenciatura en Química. Luego estudió Medicina en la McGill University en Montreal. Y luego estudió Oftalmología en la British Columbia de Vancouver. Luego de 8 años de estar en el Instituto Nacional del Ojo, en Bethesda, trabajó con el profesor Robert Nussenblatt, una referencia mundial en uveitis, y luego hizo un fellowship en el Wilmer Eye Institute en cirugía vitreoretinal en Baltimore. Luego, los próximos 10 años, se comportó como el jefe del departamento de oftalmología en Holanda, en Ámsterdam, se mudó a Europa y fue a Holanda, y luego finalmente terminó en Suiza, en Lausanne, donde fundó y es el director del Centro de Cirugía Microinvasiva, el MIOS. Luego es el cofundador del CMO de Preselles, una especie de enlace con la Universidad Técnica de Eindhoven, en la cual comenzó hace prácticamente 15 años, en el 2005, para explorar el uso de micromanipuladores y cirugía robótica en la especialidad vitreoretina. Preselles fue creada para el desarrollo y comercialización de la cirugía y la plataforma robótica para cirugía intraocular, y es utilizada en Oxford, en Inglaterra, como el primer ojo humano robótico, y a partir de ahí se han desarrollado una enorme cantidad de dispositivos para la cirugía robótica intraocular. Entre ellos, los dispositivos de liberación subretinal, la canulación de cirugía vascular en oclusiones venosas retinales, y obviamente ha logrado un desarrollo fundamental que está intentando lograr su aprobación en la FDA hoy, en Estados Unidos, para lograr cirugía robótica. Es también un cofundador de una biofarma que se llama CMO Ocular in Oxford, en UK, en Gran Bretaña, una compañía en desarrollo de dispositivos de cirugía supracoroidea y de microesferas para liberación sostenida de drogas intraoculares. En sus especialistas o en sus áreas de interés, el profesor Smet ha trabajado mucho, ya dijimos, con el profesor Nussenblatt en Estados Unidos, en uveitis, es un experto uveitólogo, y en el tratamiento de patología inflamatoria en vitreoretina, y también en imágenes multimodales como el OCT y la autofluorescencia. Fue comprometido en el grupo de aprobación del Foscarnet, ¿se acuerdan? En la época del citomegalovirus, ya por la década del 80-90, y fue parte del tratamiento de investigación del Foscarnet como antiviral, y también para el tratamiento del linfoma, y del metotrexate, fue el primero en utilizar metotrexate adaptado para pacientes de tuberculosis y patología inflamatoria con neovascularización. Es obviamente socio y parte de la Escuela de Ingeniería y del Manejo en Suiza, y ha trabajado con cirugía intraocular endoscópica para cirugía intraocular, algunos procedimientos que hagan en Argentina, algunos colegas lo utilizan, y también en Brasil. Y también está explorando junto con el doctor Stanislao Rizzo, en Italia, en Florencia, el uso de membrana liofilizada amniótica para el tratamiento de agujeros maculares crónicos y de desgarros de retina. Es miembro, obviamente, de una innumerable cantidad de sociedades médicas científicas en uveitis y en retina, fundamentalmente el selecto Club Jules Gonen, la Macular Society, el Grupo Internacional de Uveitis de Estudio, y en la cual es el actual tesorero. Y obviamente es editor en board de numerosas revistas indexadas en PubMed. Ha publicado nada más y nada menos que 180 trabajos publicados en revistas internacionales, es coautor de 22 capítulos de libros y ha dado casi 250 lectures a nivel global. Dr. Smet, it's a very pleasure for us, it's a very honor for our department in the University of Buenos Aires to have you with us. And we have a really welcome to you, and we appreciate your collaboration and to have your time in this pandemic situation all over the world. So thank you again for sharing your time.
Okay, well, muchas gracias. Hablo un poco español, pero no suficiente para hablar por 1 hora y media. So you'll have to excuse me if I have to switch to English. I wish I could do better, because what you did not mention is my wife is Spanish. And so it's a tremendous shame that I married her too quickly. And so did not have to make more effort in learning Spanish so far, but I did understand everything you said.
Great.
So having said that, you've asked me if we can, I can share my screen.
Yes.
And the host has to do that apparently for me. We're going to look at three subjects. One is going to be macular holes. The second will be vitreoretinal surgery. And then we'll talk a little bit about COVID, both in terms of what we faced and hopefully what you will not have to face, and some of the issues, at least for us as ophthalmologists. So it says here that the host disabled attendee screen sharing, so I would need to be able to do that.
Sergio, ¿lo haces vos eso? ¿Le compartís pantalla?
Yep, you're ready. Try again.
Okay, let's go. Yes, perfect. So I'll switch to the first screen. We'll go to share, and then I'll put this as a presentation. Exactly. So there we go.
That's perfect.
So this is a bit of a specialized talk in some ways, because we're not going to talk about primary macular holes, but why holes fail, and why do holes reopen? And in some ways, maybe for those who are not vitreoretinal surgeons, why are we still today, when macular holes were first, in fact, treated in the 90s, still looking for new ways to be able to close them, using flaps and using different types of things? And maybe just as a very broad background, if we look at the macular hole surgery, I like a comment that Blumenkrantz made years ago, and I met him once at a meeting, and he said, if one of my fellows operates the same way as I told him 10 years later, he's doing something wrong. And I think this is true for all surgeries, but in particular for retina. And with macular hole surgery, we first started by just doing a vitrectomy and using gas. We then went to using platelet concentrates. We did peeling. We then did some staining. And now we're getting into flaps, and different cutters may help to be able to get rid of vitreous in a better way. And, you know, in the future, and I'll show you at the very end, robotics may even be able to play a role in that, in being able to simplify the surgery, because there are two aims in macular surgery and macular hole surgery, is to simplify the surgery on the one hand, and on the other, to be able to get better results and be able to deal with those cases that are difficult to treat. For those of you who don't know, we have new devices that allow us to see inside the eye very clearly. And you see here two images of the same fundus. And if you're good at doing stereopsis, you should be able to get these two images together. And you can see in 3 dimensions. So this is the Ingenuity system by Alcon. Zeiss also has a system now that allows you to see in 3D. The big advantage of these systems is you reduce the amount of lighting. And the other is that it does give you a bit better depth perception and allows us to be more precise in those movements we make close to the fovea. By reducing light and being able to adjust it, it also makes it easier for us to sometimes be able to increase the contrast in order to see the membranes that are at the level of the retinal surface. And so here, for example, if you really look at it, you'd be able to see that the vitreous is a bit easier to see in this particular contrast. We do see something floating in the middle. And in the case of macular holes, one of the questions is always, is it just the hole that is opening the retina that has a small tear, or is there a piece of the retina that has come completely loose at the moment the traction released itself? And so that we're not only dealing with a hole inside the retina, but loss of tissue. This just shows you a little bit more with regards to removing the vitreous. You can also change the color. It allows you to see the vitreous very often a little bit better. And again, here we have this material that accumulated and needs to be removed. Contrast can be enhanced by using dyes. Early on, we used, as in the US still today, indocyanine or infracyanine. The problem with this dye, particularly in the setting of a macular hole, is that it does allow you to see the membrane. And while initially, before we used dyes, we had maybe 85% success or 90% success in peeling the membrane and enclosing the hole, the use of ICG allows you to have 100% success, but it reduces the improvement in vision. And using these dyes like Brilliant Blue allows you to remove the membrane, but also to see improvement in visions, usually by 2 to 3 lines once you've completed your peel. And you can see here that you can pick, and by changing the lighting, you can often have some improvement in the contrast, which facilitates the ability to remove these membranes. So what we do know is that if you have a small macular hole, such as this one, these usually respond extremely well to surgery. In fact, I think all of us that have done vitreoretinal surgery, if we have a small hole, on occasion nurses give you the wrong mix of gas, and we find that after a few days, the gas has disappeared. I sometimes wonder whether they put gas in it or it's just air, and yet the holes will close. Here we see a case where just a month or two later, we see that there's nearly complete closure. We start seeing reintegration of the various layers that are present. And that's in fact essential if we want to get improvement and restoration of vision. That is, as the hole closes, we should on the OCT be able to see that the contour comes back to a normal contour. And if we have this type of configuration, we can get back to 100% vision. And usually these holes remain closed and don't reopen, which is of course what we want. Now, there has been an open question for a very long time, and that question has been, how much posturing is really required? And the secondary question is, how much and when do we really need to peel? Now, posturing has been an issue. When I first started, we would position people face down, lying down for at least 2 weeks. We would use long-acting gases. And despite doing that, because we weren't peeling, we only had about 85%, 90% success. And posturing itself is only really required insofar as you want to keep air or gas against the surface of the hole. After all, what closes the hole is really more the surface tension of the along the edge of that bubble that prevents fluid from getting into the area of the hole. The second thing is you want to have it there long enough so that we get a plug of fibrin or other material in there that will be able to hold this hole closed once the gas disappears. Now, what would cause it to reopen is if we have something on the surface that pulls the hole open, again in a tangential direction, reason for which we peel, and we usually peel when we have fairly large holes because those are the ones where we feel that just being able to close it won't be sufficient to overcome this tension that pulls the edges of the hole open in a centrifugal direction. So is face down really necessary? And there's been a debate for a long time, and this I think is a very nice article that comes from Copenhagen, and it essentially looks at face down positioning for essentially 2 weeks versus non-supine positioning, which means that the patient can stay upright and potentially spend more time trying to read looking down, but not having to do much more than that. And you find that the hole closure is essentially the same. There is really no difference with regards to that. If we look at the size of the hole, there is in fact no difference either. In fact, in this particular case, maybe it's even a little bit better in the non-supine positioning. Same is true for large macular holes. And what you find, in fact, is that there's not much difference between the two. However, here the peel was of 2 disc diameters around the edge of the hole, and he did use C3F8, which is a gas that will persist inside the eye for a very long period of time. So this is good if you're living in Copenhagen, in Denmark, and you don't have mountains around you, but it would be problematic for my patient population now because many of them live at 1,000 meters. There is a difference in height. And a gas that can expand would end up giving some pressure. So here I have to ask them in that case to stay with friends or family in the valley in Lausanne And with C3F8, that can be up to a month's time. So other alternatives might be nice if we can avoid it. But important, face down positioning is not essential. If you have sufficient gas to cover the macular area for a sufficient length of time, patients do fine. What about the extent of the peel? How much should really be done? Well, this article would suggest, in fact, that if you peel more, you end up getting better results. And this is particularly true if you have a larger hole. And what they've done in this study, they didn't just look at the size of the hole at its at the middle point of the retinal detachment, the retinal hole. They also looked at the relationship between the inner part of the retina that is elevated and the base, and came to a ratio where they took these measurements of this retinal elevation to the base divided by the size of that hole at its very base. And so this gives you an idea of the area that can be closed as the retina comes back into its normal position. And if it's relatively small, that is, you have a high ratio, in that case, peeling more or less doesn't make that much of a difference. But if you have a very large base and the retina has been pulled back a considerable amount, being able to peel over a larger area does tend to give you better results in terms of outcome. And this at 3, 6, or 12 months. And this is often what we see is patients that come back with a recurrent macular hole, doing the OCT. At the area along the edge of the hole, there isn't much membrane left, but some may be present further out. And sometimes with staining, we're able to see, as is shown in this picture on the right, that the peel was good, but there might still be some traction further out, and removing that membrane on the edge might be of some use. However, what we tend to do today is to try to create a flap, and trying to create a flap with already this type of configuration becomes rather difficult. Now, I've mentioned earlier that we can have macular holes with lost operculum, so we've lost tissue. It's not a huge hole, but it is considered large. It's over 400 microns. That's a minimum diameter inside the retina. And you can use indeed a flap that will help you to close the hole. But as I've mentioned earlier, even though we've closed the hole and it remains closed for a period of time, even a year later, we still have a gap that is present here. And because of that gap, the improvement in vision that we have in this patient remains rather limited. And it would be nice to be able to get this a little bit closer together if we can. And there is no simple solution for that, but there are other options that one can consider. For example, the use of platelet concentrates, where sometimes there is a bit of a tendency for the hole to close. Another approach, which I'll mention in passing, is you can consider, for example, to elevate the retina. That is, to inject fluid through the retina so that the edges free themselves. And this is what is also done, I believe, in Sao Paulo in Brazil. By liberating the edges of the hole, we then allow it to reapproximate better rather than to be stuck to the underlying retina. Another consideration is, what should you do with a second eye? So this is the first eye of a patient, large hole. Patient was operated by a very good vitreoretinal surgeon, and yet we developed atrophy in the macular area. The hole itself is closed, but there's definitely loss in vision. So what should we do with this particular eye with regards to repairing it? We have a membrane that is present on the surface. It's clear that removing it would make a difference, but we find a retina where there are no cysts that are present inside the retina itself. That's already a sign of a chronic situation that might be difficult to heal. We see here a little bit of retina, so it may close, but not completely if things go well. And we have a large membrane that can, of course, be peeled. So one approach here would be to use platelet concentrates. You can see here that there is some reintegration that is occurring, but over time, 24 months, as you can see here, the reintegration is maybe not as good as we want. We've closed the hole, but there is some discontinuity in this case. And so the improvement in vision was not maybe as nice as we might have expected. And here, I think initially it would have been good to not only remove the membrane, but try to separate the retina so that it would be able to get closer together. Placing just a flap on the surface of this would not improve things with regards to the outcome. Now, in talking about bilateral macular holes, the second eye, if it's going to develop a hole, will do so usually within about 2 years. If we can intervene early, you get better outcome, but this would be true with the first hole. There is no increased risk of recurrence. It can occur, but there's no increased risk in the second eye. And as for a primary macular hole, you get the same, maybe a success that is a bit less than what we would have today. But in essence, if it occurs in the second eye, it's like if you had a new hole, it just will respond in a very similar way. And if it is going to recur, it's going to recur within about the first 6 months, which is about what you also see in the cases of simple macular holes that recur. So what about high myopes in the second eye? Well, they can occur, obviously. And I'm showing you this for another reason also, because here we have a patient that had a macular hole in the other eye with a moderately good repair. This eye has been operated for a cataract about a week before and is sent to me. And you can see a small hole. This should respond very nicely to the use of SF6, which is usually what I use. It might even respond to the use of gas or air, since there's very little membrane present on the surface. And this is the result the day after surgery under air. You can see that there is a plug. The retina itself is closed. A week later, very nice little plug that is present here with a good contour, disappearance of any of the cysts that are present. And hold and behold, a patient comes back 2 months after the surgery and he has again a retinal detachment, a macular hole with a lot of edema. So why did the hole recur in this case? And if we really look a little bit further, we see that there was a membrane present. Is it a persistence of a membrane in this case? Well, not really. We don't see any membrane the second time around, maybe further out, but not all that much present. But if we go deeper inside the retina, we see this cystoid pattern that is present inside the eye. And on fluorescein, it's a definite cystoid pattern. And in fact, because of the cataract operation, this particular individual developed a Irvin-Gass syndrome that pulls the retina outwards and essentially reopened the hole that had been successfully operated and had completely closed. So if we look at the risk factors for recurrent macular holes, high myopia is a factor. But more important, and this can be delayed sometimes by years, is the fact that somebody may be operated for by cataract surgery. So if we combine the cataract surgery and CME that occurs before the reopening, we find that this represents more than 50% of patients. So this is one of the major causes for recurrences. Residual membranes may be the case, and the development of cystoid macular edema following cataract surgery seems to be a significant component. And if you follow patients, you find that there are a certain number that may develop macular holes because there is residual traction that is present inside these eyes. But I think, this is an important element which I wasn't really aware of, but is certainly worthwhile taking into account. So the treatment there would be certainly to try and take care of the cystoid macular edema. And at the same time, I think for those patients, it's important to close the hole by being able to place something on the surface. And now the question is what is the best tamponade that we can use to be able to close it long term? We could try and use the platelet concentrates. The way I prepare them is simply to ask the anesthesiologist to take some blood, allow it to clot, and then we take the serum on top, the plasma on top, which essentially contains a lot of activated products from platelets that have essentially coalesced. And that is a very simple way to be able to close holes. However, people over the years have looked at other means of doing that. And this becomes very important in situations like these, where we have here a failed lamellar hole that was sent to me. There is very little edema in the retina. There's even elevation at this side. There is no membrane left on the surface, so we had to go and get a membrane elsewhere that was positioned here in the center. We use silicone oil in this case to be able to close the hole because it didn't really seem like it would really achieve any good results. We were able to close. There's a bit of a remnant of this membrane here, but the vision itself didn't improve all that much, and we ended up anyway with some atrophy in the central area corresponding to the area of that elevation that you saw earlier. And you can see here that in this elderly person, 80 years old, maybe due to the light exposure, maybe simply from the toxicity of silicone oil or others, we didn't really have the improvement that we had expected. So to try and close holes, particularly in myopes, in recurrent macular holes, as we've discussed, the inverted flap technique was proposed. And what it is that as you're removing the ILM, you fold it so that it covers the hole. And then as you put gas into the eye, it will close it and prevent fluid from coming in. This is a technique that works quite well. Others have suggested the use of a neurosensory plug where you remove retina and choroid in the periphery, in particular retina in the periphery, and you transpose it into the hole to be able to close it. Some have suggested that you might have reintegration of this retina tissue within the hole. I don't think this takes place. And I find this a very aggressive approach because there is the risk, in fact, of developing PVR from the loss of pigment. And so I don't really recommend this particular approach when using this, this approach. Others have used, and this comes from China, you can also remove the posterior capsule. And if you cut the posterior capsule out, this could be positioned on the surface of the retina, or as the Chinese have tried, to insert it through the macular hole into the subretinal space so that it closes it from the other side. It provides a scaffold on which the retina is able to move to close. If you put it under the retina, it tends to persist and doesn't disappear. On the surface of the retina, over time, it does. So I've mentioned the release of the subretinal adherents. This was published by Kirsten Meyer here in Switzerland, and he's used it in cases of failed conventional C3F8, so a gas that should really be able to close holes in a long time, or failed oil. And the importance here is that you're going to use the same technique as for macular translocation. You inject fluid somewhere in the temporal side, preferably, but you may have to make more than one hole to essentially elevate the retina and then flatten it. His results were good. It's a very limited study, though, that he published. Other good surgeons in Europe have tried it. The results are variable. Some like this approach. I haven't used it so far, but certainly would consider it in a very large hole such as this one here, where even if we close, we wouldn't really be able to reapproximate the edges. Another approach which was mentioned a little bit earlier, and I think is worthwhile to consider for the future, is the use of amniotic membranes. So they've been used in ophthalmology, as some of you know, for quite a while now to cover epithelial corneal lesions, in particular, corneal ulcers. In bullous keratopathy, it works very well. It helps in the healing of chemical burns. I've used it also for band keratopathy that develops in patients that were being treated, that had developed BK as a result of oil in the anterior chamber. And to my surprise, when you use these amniotic membranes, there is no pain associated. So it is certainly a very nice material that contains growth factors that essentially will help to limit the amount of pain, but potentially might be also good if we want to use it in the retina, because there are some epithelial progenitor cells that might be present if it's a fresh membrane, or they may contain also some growth factors that can help the RPE to proliferate, migrate, and reform the surface that is required for the retina to occupy the area of the hole. This is the approach that Rizzo has developed. So he's created small little membranes. They were originally fresh membranes. The ones I've used are lyophilized, so they've been treated and freeze-dried and then dried in such a way that they sit in a box that can stay on your shelf for 2 years. And if you need them, you can just take them, cut them down to the size, or have them given to you with the right size to be able to place either on the surface or under the retina. So in his approach, and you'll be able to see it, I think in the next, this is another one with fresh membranes where he's placed it under the retina. It allows the retina to close. He feels that the retina migrates over the surface of this membrane to close the hole, and he does find some improvement in vision. And you can see here, this is a video that he's sent to me, essentially the procedure itself, where he goes in with a tiny membrane, as you can see here, a disc that is inserted inside the eye. And when he brings it inside the eye, he's then able to position it next to the hole, and then with a spatula will fit it into the edge of the hole so that it is under. And part of the reason for wanting to do that is that the membrane itself is very tends to stick to perfluoron, and so if you try to put it on the surface of the retina under perfluoron, it moves around in all kinds of directions and doesn't stay at the right space. You can see it's quite transparent. You then bring it in, and then you shove it through the hole, and if you have a very poorly pigmented retina, that makes it more difficult. Having an IOCT will facilitate the process itself. So having looked at this, this is nice. You have to be a good surgeon. You need to have what is required for it. I tried a slightly different technique in this patient I showed you earlier with a hole that reopened because of Irvin gas. And we placed the membrane directly on the surface of the retina. And this is taken a few days after that second surgery. And you can see that the hole is very nicely closed. I didn't have a punch, so I cut it freehand, which looks a little bit horrible, I think, when you look at it. But placing it on the retinal surface, it sticks there. And to this day has remained in this position. But the vision improved from 0.05 to now 0.5. Even though the membrane is still covering the macular area, but it is getting somewhat thinner and hopefully will disappear over time. This is a patient that had a somewhat larger macular hole, more chronic. She had a very bad cornea, which made visualization difficult. We used a much thinner membrane that was placed on the surface, and you can see here that within about a week, there is in fact, or 2 weeks rather, there is a good closure of the hole. And there was an improvement in vision by about 1.5 lines. This membrane, after about 2 months, pulled off spontaneously from the retinal surface, and the retina has remained closed ever since. You can see here at 2 months, and you can see here at 9 months, the hole itself is perfectly closed. We've gone on to using small membranes that are made by a punch, and we've used it recently and tried to stuff it inside the retina. We can see here that the hole itself is closed. We don't have any edema left, but it is not necessarily causing the edges aren't yet completely at the normal position. This is shrinking, so I still have good hope that within a month or two, we'll see the membrane disappear and the hole take on its normal shape. However, this last membrane was placed under air to try and avoid the use of perfluoron. In the same way, this is now using a robot. What we would like to do is to be able to hold the membrane in place delicately over the hole and be able to do on the side an air fluid exchange that would allow us essentially just to position a membrane, whether it's an amniotic membrane or something else that would close the hole in an atraumatic fashion in a very controlled way. The difficulty in trying to bring a membrane like this under air is, of course, the visualization that you have of the exact positioning. And since I don't have an IOCT, this makes it a little bit complicated at this time. This would obviously be quite simple because once you hold it in place with your robot, it will not move. But that's, of course, the subject of our next talk. And so this is the end of the first talk. If you have any questions, please feel free to ask them.
Thank you, Marc. You will open the discussion with our panel, Dr. Juan Pablo Franco, San Juan Cortalesin, and our chairman, Professor Chiaradia, to ask some questions. And also we have some questions on over the chat. I want to make you a very easy question. What is the key points of your decision to choose the technique in the first time macular hole surgery? The size, the time, the follow-up, so the fat kick, the myopic, because we have a lot of techniques now, as you excellently show. But in the first time macular hole surgery, what you see on the OCT to decide what technique you can use?
The most important thing, I think, is size and configuration. So if you have a small size, whether you're going to use, you don't necessarily need to peel. So anything that is 250 microns or less, you can essentially close by doing a vitrectomy and then doing an air fluid gas exchange, and usually that's enough. If you have 400 micron size or larger at its minimal diameter, these usually will require some degree of peeling, and then may require either more gas, or what I usually try to do is to leave an inverted flap to close that hole. If these are lamellar holes or you have myopic holes, then you're probably better off to try and close them with something in addition to make sure that it does not reopen. But the most important thing is the size of the hole when you first see the patient. Great.
And the second question of my side is, when you use the amniotic membrane, the lyophil side amniotic membrane, during the intra-op manipulation of the membrane, what do you put over the retina? You put the epithelium, you put the chorion. How do you manipulate the tissue inside the eye? And how do you realize that you're putting the chorion over the retina?
That's still a bit of a problem. You're right that you want to have the chorion because it tends to stick a little bit more. So that's what you want to be able to get to that surface. If you're able to pick it up, knowing where the chorion is, you pick it up, you bring it inside the eye, you turn it in such a way that it does end up sticking to the retinal surface. But if you lose it at the present time, it's very hard to be able to do that. So then you either have to go to a second disc, as you've seen, there are several there, or otherwise you have to try and just hold it in the right position. Some other individuals have tried, and they did not feel that it made such a difference whether you were on the epithelial side or the chorion. But if you can, chorion is better.
Great. Juanpi, any question, Juanpi?
Yes, doctor, thank you for your presentation. In case you have, I noticed that you operate some patients that have AMD, non-exudative AMD. Are you afraid if any of these patients may transform to the exudative form? With the surgery, I mean, in macular hole, and patient also with the non-exudative AMD?
Well, no, I usually try to do just the ones that have myopia, but no, in fact, if anything, the fact of doing a vitrectomy in most of these patients reduces the risk of getting an active neovascularization. There was, I'm sure you'll recall, a debate for a while with regards to the use of a vitrectomy even in patients with AMD, because that seemed to reduce the risk of developing a neovascular membrane. You increase oxygenation, and that seemed to help the situation. You remove traction from the vitreous. If you're able to remove traction, that also seems to have a beneficial effect. Although when it was studied, it didn't really make that much of a difference in a larger study. So I try to avoid AMD if I can, but if this is the best eye, I will perform the surgery to try and close the hole. And I haven't really had cases where we've seen reactivation of wet AMD.
Juancito?
Yes, good morning, Marc. One question only. Many people say that the retinal transplantation works, and you say that it's not the choice that you will take. What do you think? It has some kind of future, that kind of surgery, or it's just a temporary surgery that many people say perhaps will work?
Well, I have my doubts as to the reintegration part. We know that the ILM works, and the Chinese have shown that using the posterior capsule works. So closing the hole, I think, is the key element. So why increase the risk of having PVR or other problems by taking a piece of retina, particularly if you can have access to something like an amniotic membrane? The advantage then, the big advantage I think of of taking a piece of retina is removing the ILM beyond the area of the macula is difficult. It's very thin. You expose yourself to creating a tear anyway in the retina. So why not take the retina? I think part of the logic is there. I don't believe there is reintegration. There is no reason why the retina should reintegrate. And if it's factors that help the hole to close, then we should be able to get even more factors if we're going to use an amniotic membrane. And that's why I think the future is more in that direction. Find something that is less damaging to the retina with less risk of developing other complications such as PVR. And I hope we can evolve in that direction. But, you know, I may be wrong. I've never used the retinal transplantation because I don't believe it makes personally, you know, a scientific sense.
Okay, and one more about the techniques of internal how do you say, membrane to put over the hole. Which side is the best to manage inside the eye? 400, for example, if the hole is about 500 millimeter, how big must be the membrane to put over the eye? 1,000?
That's a good point. I'm not sure yet, but I think, you know, you should have something that at least is half a disc diameter larger than the hole itself on all sides. So if you have a hole that would measure, let's say 500 microns, it would be nice to have a membrane of about 1,000. And it should be thin because after a while it will essentially just pull off on its own, and you really only seem to need it for the first month. After the first month, if the hole has closed, it remains closed.
So, okay, thank you.
Thank you.
Professor Cardia, yes, our chairman. Thank you.
First of all, thank you very much. We are very, very grateful about your speaker. And can you share with us if you have any other experience with amniotic membrane? Because I apologize, I came from the cornea world. So we are working with amniotic membrane for more than almost 2 decades. Do you have any experience with retinal detachment and amniotic membrane?
I don't with retinal detachment, but Rizzo has used it. He's used it to close peripheral holes, and also in Devin in the southern part of France, in Marseille, has used it also to close peripheral holes. And it, according to both, it does work. So that's something I'd like to explore later. I think it's an interesting idea to be able to use a membrane that can be cut to the appropriate size so that you're able to close peripheral holes. But of course, there, it most likely will work if there is no PVR and traction. If there is traction, even though you close the hole, if the traction recurs, it won't necessarily stay there forever. So it still needs to be explored more. But for let's say, a standard hole that we should be able to close with just C3F8, it will work. And I think there maybe the advantage is that in a place where you have mountains, and you certainly have them in Argentina like I do here, finding ways to be able to close a hole quickly with just air makes a huge difference. So it's something that is worth exploring.
And please, just one more question. Can you tell us what kind of amniotic membrane usually do you use? Is it freeze membrane? No.
No, what I have is a lyophilized membrane. So these are processed by a company in Lyon, France. They get the placenta from, I guess, different sources in France. They test them for viruses and various other things. And then they remove different parts and they freeze. These are lyophilized, so freeze-dried tissue. They come in a dried form. And initially, I would cut them using scissors. They've now sent them to me with punches so that they have a certain size. And they just have to be rehydrated in normal saline. The only problem with the rehydration is you're essentially better off to pick a dry membrane with a pair of forceps, hydrated at the edge of the eye, and then bring it in directly into the vitreous cavity, because they rehydrate very quickly. And once they're rehydrated, it's impossible to cut or do anything with them. So it can only be done in a dry form.
Yeah. Thanks a lot. Thanks.
Thank you, Mark. I'm going to, instead of the time, I'm going to do the last question of this topic, this chat question. I asking us about when you use the amniotic membrane, do you routinely peel the ILM or just put the amniotic membrane instead on the recurrent
Again,
macular holes?
it depends on the size of the hole. In that first patient, I did not, but the membrane had already been peeled. If it's a small hole, you probably don't need the membrane. If it's a larger hole, you're better off to, at this stage, I would still peel, because I'm not sure how long the membrane always stays on the surface of the retina. That second to last case was peeled. It did, get loose after somewhere between 1 and 2 months. And if you still had a membrane present, there might have been a tendency for it to open up again. It's a good question. Maybe it's not necessary, but I think for that, we need more people to get involved to try this and find out what really is required. If we don't need to peel, that would of course be fantastic. It makes the operation even easier, but I don't know at this stage. We're still in the early process.
Thank you, Mark. So we can now pass to the second point of the topic about the robotic technique. If you
Yes,
can.
I just have to switch now presentations.
Thank you.
So we'll get rid of the first and we'll go on to the next. And I just have to make sure that I'm still sharing my screen, which I'll do now. Share.
Great.
So you were particularly excited with this topic, if I remember well.
Yes.
So this is a very new topic in some ways, because we're going to talk about robotics. And, robotics is revolutionizing medicine. It's been around in many areas. We might not necessarily realize it, but it's there in different ways. And it's also changing the way we look at imaging. If we think about AI, which is in some ways artificial intelligence, it's using deep learning. And I think it's changing the way radiology and pathology is being done. And it's going to be the same in the way we look at OCT imaging in the future. But it's also been around in our daily lives for a long time. And in heavy industry, it's replaced a lot of workers, particularly in areas where there is danger to humans. So it's used also in conflict areas and in high-risk situations. For example, if you need to demine, and it can also, on the other hand, help individuals that have to do repetitive tasks that may be difficult to carry out. For example, providing body support, prosthesis for people that have lost, some limbs. And as we have an elderly population, providing telepresence. And maybe if COVID lasts too long, we may have to start thinking about using things like that too, to help us along. So the first time I gave some of these talks on robotics inside the eye, I had Manfred Spitznaz that sent me an email to tell me that I was not the first person to use micro manipulators. He was. And indeed, in 1983, when I, in fact, just had finished medical school, he published an article where he had operated about 250 people using this system developed by Zeiss for him. And in fact, Zeiss told me that they found one of these old systems somewhere in I don't know if they have a place where they keep all this, but they did find it full of dust. And he stopped using it because we had micro instruments. And as micro instruments developed, he did not need to use this machine, this coarse machine, to do a vitrectomy. But I think, if we really think about it, we're reaching now the limits of microsurgery, because we're now trying to do things in the subretinal space. If we think about our macular hole, if we could get the retina to come closer together or have a tiny little membrane that would just close the hole in the right way, that would be perfectly okay for us. So what robotics offers is augmented surgical capacities. It can assist us with positioning. An important thing is that it limits tremor. And so we all have a tremor of about 100 microns. And so, the robot itself, when it does things on its own, has a precision of about 2 to 3 microns. It decreases to about 20 microns if we put a human inside that equation, particularly if we look at depth perception on a standard microscope. It reduces also because our depth perception is limited. It tends to be better if you're looking at a screen, for example, like what Ingenuity is. You can scale forces in motion. You can constrain your activity, so you can't go beyond a safe zone as you're operating inside the eye. So for those of you that train fellows, I would only allow my fellow to start peeling as one of the last things he did, because I can't control whether he puts too much pressure on the retina or not. And so placing constraints increases safety. And certainly if you're going to do it now in an environment where you, for example, don't see as well as you're doing a fluid gas exchange, it increases your safety a lot. Motion stops and task suspension. Could you ever imagine a world where you're doing your vitrectomy, you're doing a case in diabetics and you're peeling and you just want to be able to pause to see where you should start dissecting the next stage of your dissection? That you can do with a robot. You can just suspend the task and think about what you're going to do. You could even decide at some point, where we do have plans for that, we haven't put it into place, where you could essentially exchange instruments, come back to the exact same place you were. So from using a dissector to scissors, and just continue with what you're doing. Now, the challenge is all of these things are nice, but if we're going to limit hand tremor, for example, it means that we might get to a point where we're limiting the speed at which things occur. And so there's a delay. And so filtering can be good, but it may also lead to some lags in terms of how surgery is done. We're used to operate in a certain way, so that one of the challenges as we're trying to do to create a robot that will function, it has to be intuitive for the surgeon. I like the analogy of, and this goes back to some work I did for J&J in the time trying to develop some new surgical techniques for subretinal cell injections. A vitreoretinal surgeon, and I think all ophthalmic surgeons, we all feel somewhere deep down that we're a bit like James Bond. And you know what James Bond does when he gets a new car or a new device from M is he's given the instruction book, and the next thing you see in the film is he throws it up in the air. There are some machine guns that just destroy the instruction, because who wants to read an instruction? The same thing is true for robotics. If it's going to be adopted, the surgeon has to feel that he knows what goes on, but he doesn't need to know everything about it. So you can have coarse motions, but as we get to the retinal surface, it becomes fine motions. And as we do that transition, it should occur very quickly. Optical tracking systems we don't have presently, but they will come in the future. And there may be other ways of being able to increase freedom inside the eye by having instruments that would bend inside the eye in different directions. Sorry. However, if it does that, it may add some other problems, because then if a patient moves and you've a very contorted device that is inside the eye, removing it quickly might become a bit more difficult. And this is one of the things that people have argued with me about the safety of robots. But robots are safe. We've talked about the ergonomy, the design in some ways. And if you think about Da Vinci, it's a large machine because it's made to operate US patients in their abdomen, so it needs to be massive. When we're talking about the eye, we want something small that is just next to the eye, and this is essentially what we've tried to develop. We've thought about the functions that need to be in there and the type of reach we want inside the eye. Safety is, of course, an issue. This is what Da Vinci looks like for those of you who haven't seen it before. And if we're thinking about the eye, these are the main approaches that can be considered. That is to say, a handheld device that's been developed in Johns Hopkins, where here we're dampening the movement that a human makes, but he is still in command. The difficulty with this is it's instrument dependent. So if you have to switch instruments, you need multiple systems of this type that are also sterile. And it's a feedback loop that has to compensate for what you do. So it has to be a very fast system with very small instruments. Co-manipulation, you assist the surgeon in carrying out a surgery, you restrain what he's able to do, but that has its own limitations. Or otherwise, we can use a telemanipulation system, and the two most developed at this stage is one from UCLA here in figure number A, or the system that was developed in the Netherlands, the Precise system that comes from the side. It's a similar design as what you saw for the co-manipulator. In fact, historically, this came first, the Precise system. The co-manipulator came 2 years later. But the design allows you to start with large movements and to scale them down so that what happens inside the eye is more minute. There are some differences in terms of support. Here you see a ring that is around the head. So if the person moves, he could potentially hit one of these rings. The precise system comes from the side, so that if it pulls out, the person can essentially move the head forward. And so it's, I think, a somewhat safer system. There are positives and negatives. So a handheld system can tremor filter. It can also improve maybe static tasks, for example, drug delivery, but there are many other things it's not able to do. Co-manipulation does a lot more, but you know, it's not quite as intuitive. It doesn't really give you a very rapid access or remote control option so that you can really use it as a full robotic system. And this is what your so it could be used for cannulation of veins, for example. This is an example of a system like this, where they claim to be 10 times more precise than what a human can. This is what we claimed at the very beginning too with our system. So it does have some potential advantages. This is a company in Leuven that does this. We've used a 10 manipulator system that allows you to also allow rapid access, remote control if we want to, and the motion is being controlled by the surgeon himself. It does translate through a computer, so it means that we can really modulate it for many kinds of uses. We've essentially right now kept working on the retina, because you have to decide on one particular operation at first. But there's no reason why we would not be able to expand it, for example, to a very fine placement of glaucoma stents inside the trabecular meshwork, or potentially use it for cataract surgery, which is what the group in UCLA is trying to do. And remotely, we may even be able to use it to do certain forms of cornea surgery, particularly if we're thinking about the endothelial transplants, although of course those work quite well. So this is what the precise system looks like. It's you have a motion controller. As you're manipulating the tip of the motion controller, you're in fact at the very tip of your instrument, which for a surgeon is a very nice thing. You're essentially, as you're peeling a membrane, you have the feeling that you're inside the eye, peeling at the surface of the retina. Something that, you know, until I've tried this system was impossible to even conceive. We're always working at a distance. Whenever we do something in the eye, whether it's cataract surgery, corneal surgery, at least endothelial corneal surgery, or retina, you have the impression you're always doing it at a distance. With this, you're at the surface of the tissue you're trying to work with. High precision, it's less than 10 microns. We get down to about 3 microns. We can filter tremor, we can scale motions. So from the surgeon standpoint, it's intuitive. It allows positional stability, memory that I've talked about before, so that, you know, for the physician, it's feel as being less strainful. It's a restful position. It's less stress. Most people that have tried it have said, well, when can I have one? And we wish it were that easy. And we'd be very happy if people wanted to buy it. But right now, it's still a relatively expensive piece of equipment. It's more meant for people who want to go on with, to help us with the development. Its current price is around 400,000 euros for those of you who are really interested. But we're hoping very soon that the price will be able to go down. It has a very good reach inside the eye. Originally, we had designed 2 arms so that it was a true robotic system. We've only developed 1 arm so far. Partly it has to do with cost, partly because for a lot of the things we need inside the retina in the retinal world, having 1 arm is sufficient to increase our ability to do surgery. The of interest, this is a representation in a cat of a face that represents 95% of the permutations of Europeans. And Europe has a lot of different people, so it might not work for people that are from the Eskimos of northern Canada, or maybe from the people down in the desert. But for the rest of people, the arm was designed to take into account the nose on the one side and to give a good reach from the temporal side temporally. This gives you an idea of the stability. We're looking at here at 5 microns in terms of the distance here. This is 100 microns. And if you're in a static position, not only do you have a 100 micron tremor, you have overshoots that go over 250 microns. And the reason for that is that we're made to move, not to hold still. And so in terms of subretinal injections, this is what you're up against if you want to really be able to inject slowly for a prolonged period of time. Transitions from one distance to the next are very quick, as you can see here. Was there a question? No?
No, it's okay, Marc.
Okay.
Continue.
And then the other question when you're looking at these type of things is you have to think in terms of accuracy and, accuracy and precision. And these are two different things. Very often robots are said to be highly precise, but they might not necessarily be accurate. This is highly precise. We always come back to the same spot, but we're off from the target. And so if we're thinking about a retinal vein, or for example, the macular area or the edge of a hole, this would be useful for us, would it? So we need both high accuracy and high precision. And in some ways, I think that within the medical world, we probably have the highest level of requirement with regards to this. You know, even for neurosurgery, you can push tissue aside. It's just when you get to the tumor that you need to be highly precise. And you could always move a little bit back to where you really want it to be. But when we're dealing with ocular tissue, both have to be there at the same time. And so this is robotic performance. It shows you an accuracy of 1 micron, 3 microns with regards to precision if it's being done on its own. And to my great chagrin, I have to say that it doesn't matter how much experience you have when it comes to XY, even a starting fellow is just as good or better than I am. But luckily, when it comes to positioning in depth in the Z direction, having experience does make a difference. And in fact, that's part of the reason why when we do a peel, it's nice for people to first have experience in working inside the vitreous cavity before they start doing it in critical areas. But again, here, if we were to look at, and I don't have this study for you here, if we were to look at simulations using the IC simulator in Copenhagen, they've shown that you can significantly improve the quality of the surgery being done by a novice, and the robot particularly there allows them to become nearly as good as their masters very quickly. And this is the experience also with Da Vinci in urology. One of the reasons why a lot of young fellows or residents that get into practice adopt a robot in prostatectomies is because it makes them as good as their masters that have virtually no bleeding. So if we want people to adopt, we have to offer real solutions. That's what we're working on. And it's nice to be assistive. We have to be able to enhance the present and be able to give new opportunities. This shows you in a simulation that was done in your retina this past year. What robotic assistance can do is compared to manual. With manual, you always get a certain degree of tremor, as you can see here. There's always a little bit of leakage present. If you're going to inject very slowly, you're able to inject through this simulated membrane, and you can create a bleb, if you wish, the injection under this area using robotic assistance. While this is possible, but more difficult in terms of reflux. So very good surgeons do better than this. I would say that about 6 out of 10 are able to inject with some degree of fluid loss, but 100% of individuals are able to do it using the robotic system. Next, I'm going to show you a video that shows you cannulation of a vein. This is in fact a glass cannula here that is injecting a 60 micron vein. We're filling up the vasculature. There's an occlusion here with the fibrin clot. We've done this for up to 20 minutes, filling and emptying the vein. You can see there's absolutely no motion. In the beginning, in these experiments in pigs, I did vitrectomies. Later on, I realized that we're going so quickly directly to the right spot that the vitrectomy wasn't necessary, and I stopped doing them. And the only thing, and we broke only these glass catheters on 1 occasion out of about 80 trials that were being done. Here we're using microplasmin, and microplasmin in fact allows you to open up the vein. So there's an occlusion here, and in about 30 seconds, you've gotten rid of a vein occlusion by using an active compound that is injected just next to the occlusion. And as we remove it, there's a bit of a bleed. That would be easy to take care of by increasing pressure and doing a bit of a vitrectomy. But I think there's some future in considering at least a less toxic form of microplasmin to try and get rid of occlusions in a simple way without necessarily having to do injections at, for more than a year. Here, once you restore it, it most likely will be restored forever. This is the first case done in humans. You mentioned earlier Oxford was the first to do it in humans. So this was a peel initiation that was done. And they've gone on to do a study where they've looked at peeling using the robot. It took more time, but they saw less superficial hemorrhages on the retina using the robot than when it was done manually. You can see here a simulation done in 2018 in your retina, where this is an Australian using the robot, his first time ever. And we're asking him to manipulate tissue inside the eye. And so it's he certainly enjoyed it a lot. He's one of those people that would love to have it. What we do see is that the tasks take more time, but you'll notice that for some individuals, it's not necessarily much worse than what you would do with manual. And one of the reasons for this is that you have to think differently when you're using a robot. In this case, we had the boundary placed just 50 microns under the retinal surface. And if you know that, you don't need to take your time to get to the retinal surface. You can go right to it and not waste any time. So that limits the amount of wasted time in getting there. And so you can do your task, which is essentially the peel itself. And when we look, for example, at the number of injuries that were created by touching the retina, for example, in the periphery, they're essentially eliminated by using the robot as compared to doing it manually. And all of these people had not really done simulations before. So this is what manual peel does. You end up touching the retina. So this would be considered a mistake. It is a bit special in that you have to get a bit into the retina in order to initiate the peel, and but this is what it looks like using IC. The precise surgical system looks a little bit like this. It's a compact system. Here you have your tissue manipulator, what you're going to use, your motion controller. The robot itself, or the micromanipulator, sits in a protected console. They're draped completely. This is in Rotterdam Eye Hospital with a surgeon that is at the helm. And you can see how it's being set up. A person usually has a fleece. It can be done under general anesthesia as shown here, but could also be done under local anesthesia. It doesn't necessarily have to be general. So the cases in Oxford were a mix of both. And it occupies a bit of space, but not in an inordinate way. Here it's being brought into position so that the surgeon can then use the manipulator that is just next to the head. So in essence, it is also on the side of the nurse, not on the side of the assistant. So it fits into existing ORs with existing OR tables, which is a big plus as compared to what is possible right now with let's say, Da Vinci and many other systems. And so the surgeon looks through the standard microscope and is able to position and use the robot to perform tasks. It's a combination of the hand and foot at the present time. We're using here a sensor, an OCTA sensor. The backside of the sensor is here. The surface of the retina is there. So this is in fact getting closer and closer to the retinal surface. And what you're noticing here, these blips are essentially the filling and emptying of the choroid as we're getting a heart pulse. What we don't realize when we're doing OCTs very often is the fact that these are reconstructed from A scan OCTs to create a B scan, and there is motion back and forth that has to do with the filling and the emptying of the choroid, and that represents about 15 to 50 microns, which if we add on respiration on top can go up to 100 microns difference in terms of positioning. And this, I think, and we still are exploring that, may be important if you want to make sure during subretinal injections of virus, for example, such as Luxturna, may be important in making sure that it stays in the right space. And here probably robotics would make a big difference. This is an interesting comparison between tremor. On the right-hand side, manual surgery as compared to what you have with the robot. You can see the degree of difference between the two. There is absolutely no motion on the robotic side as you're approaching the membrane as compared to what you have on the manual side. And another image here showing you a robotic surgery that was done in Oxford. The robot is being manipulated by Robert McLaren. And what you're seeing here is some rotation of the retina, but that has to do with, again, a person that is having a respiration with the machine as well as his heartbeat. So this is the natural motion that you might see in an eye if you weren't controlling it with both hands while you're doing your surgery. That I think we've gone over. So the other thing is mitigating risk. And robotics is, of course, something that increases risk. I'm always asked a question about, what happens if a patient moves? And I keep telling people is that when this robot comes out and you're able to use it, I don't want it to be a Boeing 737 MAX 8. We have to make everything to avoid that kind of situation. And normally engineers can do that. So first we have to understand the sources of risk. The major one is inadequate training and inadequate communication inside an OR. And what we've noticed so far is that, yes, if robotics is going to be done, you need to make sure that the nurses are well informed as to what has to be done, what steps should be done at what stage. Make sure that, you're not going to bump into things when you shouldn't be doing that, although that risk is very limited with regards, the consequences of it would be limited inside the eye. You can create a boundary so that you can't go beyond it, so that you wouldn't hit the retina, for example. And with regards to patient positioning and movement, the fleece that I showed you makes already a big difference. And if they're under anesthesia, obviously there, the anesthesiologist has to remain attentive during the whole operation, or you need to have a feedback loop, which we're working on, but haven't incorporated, so that the OCT image guides also the limitation in terms of how deep you can go. So if the eye moves forward, then all of the intraocular instruments would move forward at the same time based on where the surface of the retina was perceived on the OCT. And we're working with Zeiss to see if we can't use the existing OCT, IOCTs for that, or otherwise we'll try to incorporate it with this OCT A that I've showed you just before, so that we have a direct feedback loop inside the robot from the instrument. All companies that work on ophthalmic or medical devices have to go through this process, which is you look at where risk is associated. We've gone through a process where we've looked at all kinds of complications that can occur during vitreoretinal surgery. We've given it a certain risk, and then after that, we look at what is considered acceptable and unacceptable, and we've created a probability for this. And then we spent a lot of time trying to make sure that we would take anything that was critical and bring it down to its least possible level, so that we still have a few things that remain. If somebody develops an endophthalmitis, for example, that is a critical issue. But the risk of endophthalmitis here is related essentially to the use of the instruments that we put inside the eye, because they're fitted onto the robotic system itself. We can track what somebody does. So we have already a beginning of AI in a certain sense, and we can track what is being done. It can also help us improve the way people do surgery, and we've done that in the past. And what we're hoping is that by looking at recordings of what the robot has done, as well as recordings from videos, for example, we'll be able to partially automate certain actions, and also probably tell you as a surgeon where the risk is located when you're doing your surgery. Maybe this will be through haptic feedback, where, just as when you're playing a video game, you have your console that gives you some kind of a jolt that would tell you that you're getting maybe into trouble, or give you an auditory warning, so that it's a bit like the parking sensors, or what we have now with our vitrectomy machines or phaco machines that do have some sounds that tell us what we're doing. And this may indicate to us that we're getting into a danger area where we should be more careful. So we're trying to enhance software. We're looking at trying to automate partially procedures, but the surgeon will always be in command in terms of choosing the kind of procedure that needs to be done. and integrating either video images from the microscope or heads-up system. I'm hoping that the endoscopic system I'm working on, when it gets a bit further, would also be able to be incorporated. And in the future, what I'm hoping is that you, other people, will be able to come up with ideas on how to make the robot better. So far, we're simulating what people are doing, but we really have to think of it in terms of what the robot can. And when I finished my talk on macular holes, that was a little bit the idea, is can we devise an instrument that helps us carry out our surgery, but makes use of what the robot is able to do, hold something in place and do, for example, an air fluid gas exchange at the same time. So for the short term, we want to be able to, as a company, expand to the US. We're going to get to New York Ioneer later this year and look at leasing the system rather than selling it within the AU. Midterm, we're looking at synergies with microscopes. I've already talked about what we're trying to do with Zeiss, but we could also do it with others. And long term, my idea is that we would be able to get out of the OR and bring it to an office-based system. If everything is located around the eye, and we have a good visualization system that is compact using cameras, why do we need to sit in a very large OR? We could probably be somewhere else. And, you know, as ophthalmologists, we're facing a tremendous amount of pressure in terms of reductions in the amount of money that insurance companies are willing to pay. And if we can bring it into our offices or group practices, we have then a much better control on costs, and for the patient, it's a more direct access. And I think that's would be an interesting direction to look at. 2 years ago here in Switzerland, the Minister of Health decided to reduce our remuneration for surgery by 70% from the 31st of December to the 1st of January. And if you want a cheap cataract, you have to come to Switzerland. I get paid 70 Swiss francs for a cataract now, although the clinics get more, and so they do give us a little bit more than that amount, but this is the official tariff when it was 400 something before. So the future, I think, of surgery is here, and we'd love to have you be part of the wave as soon as we can get this a bit further. It may sound like a lot of work, and it is, but it's a very small team. These are the main people. These 4 people, let's see, are they all there? Yes, we have Garrett. Thijs worked on a PhD on this project. Martin came along a little bit later. He's a good software engineer. Yori just is also an engineer that helps us with the integration. These are some of the people that help us with regards to regulatory and quality assurance, as well as some other advisors. And I've been there since the beginning in the background, trying to get them to do the right thing and not get deviated onto other areas. So I'm trying to keep them focused on ophthalmology. And so, you know, innovation is the calling card of the future. This is innovative, and I hope we'll have it in our clinics very, very soon. Thank you.
Thank you, Marc. It's really an amazing presentation. We are watching the future. Maybe we hope maybe we watching the future in our countries. I have a small question about this exquisite show of technology, innovation, and maybe the future in our operation rooms and our offices. I remember during the beginning of the 21st century when the trocars came to our operation rooms, then the OCT, then the Ingenuity with the 3D head-up surgery. And there was a lot of controversy in the world about all this technique, but we are now routinely use it. 3D surgery, trocars, intraop OCT, intraop drugs, and that's it. So the question is, where is the really border or the limit of the robotic surgery? Is the learning curve? It's only the price? Is only to be available of the technology? What would be the most difficult tool, or the most difficult, border to access this kind of technology?
To access it, well, in part it's price, I think, and it's adoption. I think, you know, for whether it's precise or another, the biggest challenge right now is to get enough money to do the development. I mean, in some ways, when you look at this, it's a bit like the very early computers when they first came out with Apple and IBM. Yeah. You know, those early PCs, they were okay, but you know, it's getting the right formula so that a few people can get going. I told you the price is 400,000 right now, but if we could produce even a few hundred units a year, we could bring the price down to 250 or less. And part of the issue there, it's a completely different world, is how do you get investors to want to get involved? From that point on, I don't think it would take all that long to really get it out to people. The reason why I wouldn't want to send it to Argentina right now is that it still requires a bit of development. There's something called industrialization when you're doing robotics. So this machine works, it does it very reliably, but it does need still an engineer every so often to be there. And so there's something that is a completely specific field of engineering, which is to take something that works and now make it from a, let's say, I guess in the time we had Ladas, these were cars that came from China, or we want to take a Fiat and you want to make it into a Mercedes-Benz. And what, we can export or what we can really sell is when we get to the Mercedes-Benz of this. But there is really no reason at this stage with what we have that really limits the ability to go forward.
Great. Juanpi, any question?
Yeah, thank you, doctor. You have already said about the anesthesia, but here we usually use local anesthesia. What do you think about what is your percentage of patients that you use local anesthesia or general anesthesia in these cases?
I lose local anesthesia 99% of the time. It's very rare that I use general. And, the argument is mainly from Steve Charles. And, Steve is against this for the time being. But, if you know Steve Charles, whenever he's against something, that's a good sign. So, but
yes.
He does raise a good point, is that, yeah, what happens if a patient moves? But I have less patients that move when I do local anesthesia than I do if we do general. And, if it's something crucial, you keep the patient awake and you tell him, now you don't move. And the way the robot is being used right now is essentially you want to use it for specific tasks. So for those tasks, you can tell a patient, keep looking at the light, don't move, and they'll follow you. You're not going to use it necessarily for a whole operation. And by the time we get to that stage, we'll have incorporated whatever is necessary so that if the retina moves, the robot would move with it. And we've done simulations for that. If you put in that OCTA and you get, let's say, a paper or a donor eye and you move it, it retracts. And that's what you really want. And
okay.
The other thing is if you do surgery and a patient start moving, what do? You pull your instruments out and you hold your hands to keep the eye steady. So if you were using the robotic system, you would pull back on your motion controller. The instrument pulls out of the eye within about 15 milliseconds. It's as quick or quicker than what you would do yourself, and you can bring your hand to hold the head. So it's safe from that standpoint.
Juancito, una pregunta.
Yes, only one. Marc, do you think the future will replace us or we will work together? We will work as co-workers in the future?
Excellent question. So, if you're taking a plane today, you still want the pilot in that seat. And I think, it's the same thing here. I'm not trying to develop something that would replace us, and I don't think we can be replaced. A robot can do things, but we still have to tell it what to do. Now, maybe it can recognize certain patterns and we can maybe do things better. But then if you're going to do, for example, refractive surgery, you're still doing it. But in some ways, if you think about it, refractive surgery is already robotics because the rest of it is you bring in some data and it does whatever it needs to do. You may create a flap or not, but you're still in control. And I think it's going to be the same thing here, except that you're not just going to be doing flaps. You'll be either using it for macular hole, being able to repair the periphery, bring in subretinal RPEs. You'll be able to do things that, cannulate veins to get rid of occlusions. We'll be able to do things we weren't able to do before. I even think, for example, if you have von Hippel-Lindau, we could go in and put clips onto the feeding vessels things that we conceivably can't really do today. So I think it may make surgery faster. Certain things may be semi-automated that we control, but it's going to expand what we're able to do in other directions also.
Thank you.
So to me, we're still in control. We're like the pilots or the chef d'orchestre, and but we can be bypassed.
Okay.
Okay.
Okay. So Marc, now we're going to continue with the third part of the presentation. Because robotics has to be a dream for us, a very nice dream. We're going to work a lot to get all the devices, so maybe a company or to have Precise in Argentina or in our department. But
With pleasure.
I think it will be the future for our fellows, our new surgeons in Argentina, the young people doing our VR specialists.
I don't think it's that far away, but we still have a few steps to go before we can do that. So let me then maybe go quickly to the last one. I have to catch another call a little bit later. So I wanted to talk a little bit about COVID, just to give you an idea of where we are. Just to give you an idea, we've been confined just as long as you have. And if you were confined in Zermatt, this is what you'd be able to see at night. So just as everywhere, people need hope. And Switzerland is for its population, one of the most affected countries here in Western Europe in terms of numbers. However, we have never lacked the number of beds in the ICU. And, you know, it's a large group of viruses, as you know. The two that are more similar and that's important are the SARS and MERS. That SARS was about 15 years ago. And the cofactors, I think you're quite aware, are age, obesity, hypertension, etc. And those things are going to remain present for at least 10 years, but most people recover quite well from the virus itself. Mortality rates are low. They start to pick up a little bit, about 60 here in Switzerland. None of the people under 30 were ill or died, and over 80, about 15 to 16% do, but it's always associated with other comorbidities. So there's usually hypertension, obesity, diabetes, or something else that is present. Certain symptoms are well known. It's mainly fever and cough. And so I have my secretary always ask people about that, and shortness of breath. But I also ask it when the patient comes to see us. And if you're interested, the BMJ has this list of things that can be done for screening. It's mainly for GPs, but you'll notice here on the right that it's not just cough and temperature that are important. There can be fatigue, shortness of breath. There can be some headaches, but it's rather rare, chills. But we don't see what is very common with the flu or with the cold, that is sneezing and you know, that's rather rare. It's a rapid evolution and recovery, which is important, particularly if you're dealing with uveitis. You get onset of symptoms at about 7 days, and it's between 7 and 8. If necessary, they're going to have to be admitted because of shortness of breath. The ICU, if it becomes necessary, is by day 10 to day 11. And from speaking to some nurses that are working on these units, she was telling me it's in fact quite amazing. You find that you have to increase the amount of oxygen because the saturation goes down, and you do this for about an hour or two, and virtually all the time, about by hour 3 or 4, that's when they decompensate and have to go to the ICU. So it seems that it's a very programmed course, and you can see more or less when things need to be done. The severe response, when they get very bad inflammation, that's because the immune response comes in. And so the other lesson that we've learned over the last few weeks also is that for immunosuppressed patients, the ones that have uveitis, they usually do okay. They don't really get into trouble. And if they're on certain types of drugs like anti-IL-6, that's probably a good thing, because in this very late phase, there's usually what's called a cytokine storm, where you have high levels of IL-6 and other types of cytokines that in fact contribute to the disease process itself. And that's maybe worse than just the viral response itself. Protection I won't go over because I think you know. Hand hygiene is important, but it's very nice to talk about hand washes. But at one point, I couldn't even get hand sanitizer anymore. I did have enough at home. And in some areas, if in outlying areas of Argentina, they can't get it anymore, or the price goes up too high because there are some some people that are going to take advantage of this, the WHO gives you a way of being able to make a very good mixture that contains some hydrogen peroxide, and that helps to make the solution a lot more virostatic against COVID and other viruses. In my office, I separate at-risk patients from others. First of all, right now we're confined, so I've reduced the number of patients that I see at any time. Instead of seeing 4 to 5 an hour, we're down to about 1 to 2 maximum. Accompanying people are asked to wait outside, so they don't stay inside. We isolate within the waiting room, so each second chair is turned around so that they can't sit next to one another. And if there aren't too many people, we'll put them in different areas of the waiting area. And I've also separated any person who is young and potentially asymptomatic, and that's more common in the young people. They come in the afternoon. The most at-risk patient comes early in the morning. Reason being is that there's nothing in the air that might be able to transmit the virus. Patients are screened by phone before they come. When we examine them, the patient has to wear a mask. We wear a mask to protect ourselves. We have a shield on the slit lamp, and we use a lot of alcohol-based sanitizers. Probably the most important thing is the red eye in our case, and I've developed this with Ron Newman from Israel. He's in fact the one who did most of the work, I have to say. And if you see, there is an article that does indicate that less than 1% of the COVID patients will get a conjunctival congestion. It might, in fact, in part be related to the fact that when you get a fever, you also have essentially congested conjunctival vessels. But there are some nurses that have claimed that they've seen a sort of a redness that is seen around the eye, so a red shadow that appears in COVID patients. The tear film can transmit, but it's a very low transmission. 58 of 59 did not have any COVID present in their tears, but it could be present. And if there, it could, of course, cause the problem. And this is part of the reason we've put in shields. But, you know, a red eye is very common. Certainly, we're at the end of the winter, but we still had some common colds and influenza when this started. And I think you're coming into that season over there. So most of the red eyes you're going to see are due to this or dry eye, and not due to a COVID infection. But urgent red eyes need to be seen. So think still about herpes, uveitis, angle closure, trauma, or others, suspected endophthalmitis post-surgery, if there are still some being done. And, you know, most common things are going to be present, but there are certain presenting signs that may be of interest. For example, in uveitis, it's going to be acute, or there is a chronic course you know about. It may be painful in the case of a herpetic keratitis. If it's acute glaucoma, it's going to be very painful, infectious keratitis. So certain science can be very useful with regards to this. And by the way, this talk is published on the IUSG website, as well as some other websites that you'd be able to find. Virtual visits are all in now, at least here. And so, you know, they're not ideal, but you can certainly do a lot of things by internet. I have patients send me phone photos that can be taken. If they're taken at a good distance, you're able to see that somebody has blepharitis, for example, but be able to treat that adequately and see that they don't have a conjunctivitis, and this works quite well. We do ask about how the vision is doing, whether there's any pain present, and you take a good history, particularly with regards to dry eye. You need to be able to see also, screen them for corona. Are they in an epidemic area? Do they have fever or upper respiratory complaints? And if they do, you're probably best to send them to a center that deals with the coronavirus, because there are certainly centers that have ocular services. But should they end up in your office anyway, well, you know, take your time to examine them. Try to keep your distance as you're talking to them by about 2 meters if you can. And then, you know, protect yourself while you're seeing the patient, and a simple mask is probably sufficient. Although if they have COVID, then having a N95 mask may be useful, but not absolutely required. Gloves would be great, but otherwise wash your hands with alcohol after, or with soap and water. Carefully clean the slit lamp between exams. Try not to talk while you're doing your exam, or not have them talk while you're doing it, and try to limit the amount of time you spend with the patient to 15 minutes or less. And with regards to COVID and the time, you know, we need better planning. We have to think a little bit in advance, as I've told you. We need to stay safe. And, you know, we're going to get over this very soon. And oddly enough, I don't know how it is in Argentina, but when this first started, when we went to the store, there was absolutely no toilet paper left, and I don't understand why. I don't know if you have any questions, but that's in a nutshell the situation we're at right now. With regards to the overall, we're still confined. We're still going to be probably for another week or two. The first talks are to try and get the schools open again. And they're started this week to draw bloods. And they've asked physicians like me and others that are more or less do partly frontline work to have our blood taken so they can start looking at which antibody tests might be suitable to follow the population. And so I think the next step is that there will be more and more screening of individuals to see if they've already built up some immunity against the virus.
Thank you, Mark, again. There's a question over the chat about the COVID-19. What do you think about the BCG vaccine, about sensitivity and specific and to be effective against the COVID-19? Because there's some paper about that.
Yeah, I heard about that. And I have a friend, in fact, who's originally also from Buenos Aires, and she asked me the same question. And I can't give you a direct answer with regards to that. I'd be surprised that it protects you, but at the same time, if the immune system is a little bit more activated, it may have a protective effect. And the reason I say that is there's an article that came out about 6 months ago that indicates that if you've been BCG vaccinated, your risk of developing lung cancer is about less than half of what it is if you weren't. And so just the general activation of the immune system seems to be a positive thing. But whether this is significant or not with regards to BCG, I don't know. What I can tell you is that here in Switzerland, patients that are admitted to the ICU are getting hydroxychloroquine. Yes. And they're given in combination with azithromycin. The combination of the two, if given at a very early stage of the disease, just as they're starting to having problems with breathing for about 4 to 5 days, does reduce significantly the amount of viral load. And that seems to make a difference with regards to their admission to ICU.
Yes. And I read some paper about the combination of hydroxychloroquine and azithromycin, some kind of ECG heart problems because some arrhythmia problems with the
so
heart
that has to
failures.
be monitored. It's not something
Yes.
that can be just be done like this. You have to look at other cofactors. There's of course a risk associated. And so what I'm told is that here in the local hospital, in the university hospital, it's the infectious disease specialists that decide whether they're going to use it or not. But over 60% of patients do get the combination. It shouldn't be done without good supervision. The dosages are relatively high. And when you get into the cytokine storm, it not only affects the lungs, but it will give you cardiac arrhythmias. It tends to shut down the peripheral circulation. So at certain stages, the disease itself becomes so intense that the immune system causes damage everywhere, kidneys, liver, everything.
Thank you. Question from the panel. Professor Chiaradia, a question for you?
Thank you so much for your amazing lectures. And because this is Buenos Aires University, and you know, this is the third word, I want to ask you about your residency training program and how you could do a fellowship in Switzerland, because we know the reality in Italy, we know about Spain. Tell us in a few words what happened, what's going on with a retinal fellowship in Switzerland, please.
Well, I'm not in university right now, to tell you the truth. I'm in private practice. So the Swiss system is such that for universities, you have Geneva, Lausanne, Bern, Basel, and Zurich. And they do take some fellows in different disciplines. It can start at any time of year. It just is a question of applying to the direct university itself to see if they're willing to take you on as a fellow. Lausanne doesn't take many people with regards to retina at this stage, as far as I know, but I believe that in Basel and in Zurich, they certainly will. It doesn't necessarily have to be in university center. There are some hospitals, for example, in Zurich, Trimley, that also take people. I've had some fellows in the past. The problem is the cost of living here. So that is somewhat of a limitation, but it is possible. If somebody were interested, they would have to apply, and then we'd be able to see what can be done.
Thank you so much.
Thank you. Juancito, any questions? No. Juanpi, any questions?
Thank you so much for sharing for us your knowledge. Thank you so much, Professor.
Juanpi?
Oh, no, it's a pleasure. But...
No, it's a great presentation. No questions. We all know what is going to go on here in Argentina.
Well,
we are expecting what the problem in Europe we are expecting here in Argentina also.
Well, my understanding from Marcelo is that you started early to start putting in limits, which is good.
Yeah.
I think, we were caught by being close to Italy. The day it started in Italy, I came to my secretary and said, we have to start making sure that patients with conjunctivitis come at the end of the day. It took her 3 days to understand what I said. That day, I tried to get an FP2 mask and I couldn't get it. And luckily or unluckily, I had to go to the US in the beginning of March, and I got a mask over there, so I kept it preciously. What they have done here in Switzerland, I don't know if they will do it over there, and I don't know if you can do it through the university if the government doesn't, is in the local canton, in the province here, once a week I can get a box of 50 masks that are simple masks that I can also put on a patient to protect myself. And recently, because now they're starting to get more supplies, they've given us as ophthalmologists some alcohol because it's hard to come by. Last week, I got 5 FP2 masks in case I needed them and gloves. And so I think one of the things that has happened is that people or the authorities have realized that we're so close to the patient that we need extra protection. And if you can get that through to the authorities, it might be a great move as we start opening up a bit more to make sure that we don't get sick because of our work. And we're much closer, in fact, to the surface of a patient's face than a GP, for example. So we need more protection, maybe not as much as the person who intubates, but certainly more than just the regular doctor that treats a patient.
Marc, I have 2 final uveitis questions. One of Dr. Couto, our
yes,
head
yeah.
of the
Hello,
uveitis section of the department. He's on the connection. He's watching you and listening to you. Cristobal asked you about what happened with the uveitis patients that are treated with a biological agent and have COVID-19.
So with the biologic, I have one patient that was 59 years old and on Humira, so anti-TNF, and she developed COVID. 3 days before she was diagnosed, she took her last dose. She contacted me. So we withheld the dose for 2 doses. She went through the whole process and didn't have any problems. And what's interesting is if you look at the history of SARS and MERS, there were no patients that were that had passed away because of immunosuppression or transplantation. And there are 2 reports, one from an IBD clinic in Bergamo in Italy at the epicenter. And on 350 patients there, none were admitted to hospital when they would have expected at least 20 or 30 to have been admitted. And in a transplantation unit, out of 400 patients, there were 12 admitted and nobody died. So it would seem that, at least with regards to COVID, immunosuppression is not a major problem. Looking through the literature, which I did with some other people recently, we have 2 or 3 reports that indicate people that have passed away, but they all had cofactors. They were either obese, they had hypertension or other problems associated. These were transplant patients, renal transplant patients. And so the risk isn't higher than the regular population, which I think is reassuring. And so what we've recommended in general is that if we know somebody is positive, they should stop taking biologics for the duration of time during which they have COVID, the active disease, which is 2 weeks. If they need treatment because the eye is getting worse, then local treatment with Osidex is probably the better way to go. And then once the episode is passed, they can take their medication again.
Thank you. And the last question is, have you seen any uveitis related with the COVID-19?
No, so far, no.
No. Okay. So instead of the time, thank you very much. Thank you so much, Marc. It's really a pleasure for our department. I want to thank you, our webmaster, Sergio Eppelbaum, our fellow Mariano Cotic is in charge of the transmission, all our chairman, Professor Chiara Dia, and all our faculty, Dr. Juan Pablo Franco, Dr. Juan Cortalesi, Dr. Alejandro Alfano, and our fellows, Dr. Mariano Cotic and Marcos Mendaro, and Dr. Ignacio Olmedo. Thank you very much for sharing our department. A really honor, a pleasure, Marc, to have you with us this morning.
It was a pleasure.
All these amazing
pleasure is
presentations.
mine.
So keep in touch for the future.
Take
care of you and family. Thank you again.
Too. Be safe. Be safe. Bye.
Gracias a todos, un placer tenerlos presentes y estaremos conectados con nuestra actividad Ateneo de los miércoles de 9 a 10 en nuestra cátedra.
Hasta luego.
Por la conexión. Un placer.